Good morning, and thank you for joining us today to talk about the RAND 5.0 Hospital Transparency Study, key insights and results. Before we get started, I just want to talk about a quick scenario. You have a general idea of what it costs for a loaf of bread or a gallon of milk, right? So if you go to the grocery store and suddenly that gallon of milk is $20, I feel like you're going to ask some questions, maybe even shop somewhere else. We know that inflation has risen prices, but not to that extent. So, what do you do? Well, we accept this scenario in healthcare all the time. We do not know the cost of services when we visit a hospital. Why do we accept that? Why do some medical procedures cost 300% more at different locations? That's what we're going to dive into today. Hi, I'm Jennifer Austin. I'm the Senior Director of Employer Engagement and Strategic Marketing here at the Alliance, and I'm happy to be today's moderator. By the end of today's session, you'll understand the disparities in hospital pricing, but also learn how this crucial data can give self-funded employers the power to make more informed healthcare decisions. So before we get started, just a few housekeeping items. You may notice we're on a different platform. We still have you muted, but we do want to hear from you. Please use the chat and emoji buttons to ask questions so the entire group can chime in. If you need technical support from someone from the Alliance, please click on the support button you see on the bottom of your screen. We have a copy of the slides available in note-taking format. You can access those on the resources button. For broker consultants needing CE credit, you can also click on the resources button to download a copy of the attendance. You'll need to sign an email to us to request CE credits. For those requiring SHRM or HCRI credits, please email events@the-alliance.org. CE credit is only available to those watching this session live or on demand via this webinar platform. It is not available when watching via our YouTube channel. The recorded session for today's event will be made available on our events page. We'll also email that to attendees when it's available. And before I introduce Chris, just finally want to thank our sponsors, Delta Dental and National Cooperative RX. We truly appreciate your support as it allows us to bring this valuable programming to our employer members and partners. So now I'd like to ask Dr. Chris Whaley to come on. I want to welcome him back and thank him for joining us today. Chris was previously with the RAND Corporation and is now an associate professor in the Department of Health Services, Policy and Practice at Brown University School of Public Health. He received his PhD in health economics from the University of California, Berkeley, and his research focuses on healthcare price transparency and market structure. He's the lead researcher on the RAND Healthcare Price Transparency Study that we're reviewing today, and his research has been published in leading clinical, health policy, economics journals, and covered by the New York Times, Wall Street Journal, Forbes, and CNN. Chris has presented these results to state and federal policymakers, including U.S. Congress, California State Assembly, Texas House Select Committee on Healthcare Reform, the Executive Office of the President, the Congressional Budget Office, and the Federal Trade Commission. Thanks so much for being here today, Chris.
Thank you, Jennifer, and it's really great to be back, at least virtually, to the Alliance. I remember it was in person a couple years ago, and we had a great trip to Madison, and so it's great to be back and to talk about the latest round of our study results. Just some housekeeping. So this is joint work with Rosie Kerber, Dan Wang, Aaron Kaufner, and Brian Briscombe at RAND. And we've received funding from the Robert Wood Johnson Foundation, as well as many participating employers. We're doing this virtually, and it'd be great just to keep people engaged. And so if there are questions, either chime in, or I think that, as Jennifer mentioned, just send them in the chat, and we can kind of take them a little bit as they come, and then we'll have time for questions at the end. But I think Jennifer really did a good job of really kind of encapsulating why we're talking about this issue today. And as we've been doing this study, as well as other studies around the healthcare industry, there are really three economic points that I think are really important we need to keep in mind. So first, we spend a lot on healthcare, which comes at the expense of everything else that we could spend money on. And so if you're an employer, that means your own operation expenses or particular other types of benefits, typically wages for workers. We spend a lot on healthcare in the United States because of high prices. So there's a tremendous amount of variation in prices, and they typically tend to be quite a bit higher than we see in any other country. And then finally, prices are incredibly variable. As Jennifer mentioned, not at all transparent, and also importantly, not linked to quality, and instead are really driven by market structure. So we'll talk about that third point a fair amount today. And so why is this in particular important, and why are we talking about healthcare to employers? It's really just the size and the importance of employers. So employers play a critical role in the United States healthcare system. They cover or provide insurance for about half the country, about 160 million people. And collectively, employers spend about $1.3 trillion per year on healthcare costs, with the biggest chunk of that pie, just under $500 billion, going towards hospitals. And so this is a huge and incredibly important marketplace. And when we talk about healthcare policy, I think in many cases, this is despite its size and importance, the population that is really left out from many policy discussions. But as we've ignored the importance of employers, we've really seen some, I think, disturbing trends going back the last 2 decades in the market for employer-sponsored insurance. So if you look at your paycheck, there's a amount you care the most about, and that is your take-home pay. But then there's also this other thing that we kind of collectively ignore called your employer contributions towards healthcare, as well as your own individual premium contributions. And so if we just look at those two components of your paycheck, we see a pretty wide divergence. And so wages and take-home pay has basically kept up with inflation over the last 20 years. So collectively, they've both increased by about 170% over the last 2 decades. At the other side of your paycheck, the amount you spend on healthcare has really exploded. So the premiums that employers pay for healthcare on average has increased by over 350%. It now costs around $24,000 to provide health insurance for a family plan. And there's been a huge explosion in deductibles, mainly driven by high deductible plans, which have increased by almost 500%. And now it's not uncommon for many health plans to have deductibles of $5,000 or even $10,000. And so there's I think a pretty concerning problem that collectively we've decided to give workers on average pay increases in the form of healthcare dollars rather than in the form of take-home dollars. And what's contributing to that challenge? And so if we just look across the entire economy and not just healthcare, and actually look at where prices have increased the most or actually decreased over the same time period, going back to 2000, what we actually see is that hospital services have actually increased prices the most relative to any other industry in the economy. Medical services are close behind, and higher education, which has its own unique problems, is not far behind as well. But it's not just a matter of, this is a market with lots of technology and lots of innovation. If we look at other types of innovative industries, such as TVs, computer software, and cell phones, where there's just been an explosion in innovation, we have actually seen prices come down. And so there's something unique about healthcare, and in particular hospital services, that has led to a drastic increase in prices over the last 20 years. Jennifer talked earlier about the challenges in purchasing healthcare and shopping for care and knowing about prices. But if you're an employer, I think that is actually something that it needs to be crystallized a little bit more. So if you're an employer, the way you provide health insurance is you essentially take money out of a worker paycheck and give them benefits in the terms of healthcare dollars. And as purchasing that decision, self-funded employers have what's called a fiduciary obligation to make sure that they're actually doing that efficiently. And so if you look at the Department of Labor website and what they actually say are their regulations for being a responsible fiduciary, it's that you have to act solely in the interest of plan participants, which means their families and your workers and their families, and with the exclusive purpose of providing benefits to them. And so this is I think a pretty strong statement. And if you're just kind of taking a step back and thinking about healthcare, on the one hand, you have this really strong requirement to purchase efficiently and be a responsible purchaser. But if you don't even know prices, how can you actually fulfill that obligation? So I'm asked anyone else to go purchase something on my behalf, and they say, I'm going to do that, but I have no idea how much it's going to cost. That doesn't seem like a responsible fiduciary. And these fiduciary obligations are, I think, becoming much more real. So as we've been doing these studies over the last several years, one of the interesting things has been there's been a growing interest from trial attorneys and attorneys who are interested in actually legally determining what fiduciary obligations are. And we've seen some initial, I would say, lawsuits around this exact issue. And so one of the more well-known ones is a lawsuit from earlier this year where an employee, or a former employee rather, filed a lawsuit against Johnson & Johnson, her former employer, alleging that a prescription drug that was in their planned benefit was orders of magnitude more expensive than it should have been, and having that high-cost prescription drug in their planned benefit was a breach of Johnson & Johnson's fiduciary obligation. I think the unique thing about this lawsuit, or one thing that stood out to me, is that this is a lawsuit not just against Johnson & Johnson as a corporate entity, but also the individuals who are HR executives at Johnson & Johnson and have a personal obligation to be responsible fiduciaries. And so we're now in a world where not being a responsible fiduciary has led to legal challenges, not just against companies, but also against individual executives within those companies. And so that's really the background and why we wanted to do this study. And I think one thing just to be clear about, we as researchers don't know what the right price is for hospital care, and I don't think we can necessarily say this is for a given employer, this is how much you should be spending on healthcare. But at the same time, we also know that you can't be a responsible fiduciary if you don't know information about prices that are being negotiated on your behalf, and if you don't have insight into your prices. And so the number one reason why we want to do this study is to give employers, purchasers, and policymakers information on prices negotiated on their behalf and in their markets, and allow them to use that information with knowledge of their own employee populations, their own market context, and decide whether or not those prices align with the value that they're getting, and to make that economic decision. And so how do we do this? So this is the fifth round of the study, and we followed a very similar process as we've done in the past. So it's really a multi-pronged process where we spend the bulk of the time actually going out and collecting individual claims data from mainly employers, and so purchasers who want to know insight into prices negotiated on their behalf, where we're actually able to work with those employers. In many cases, they're data warehouses or their TPAs or insurers, and actually we've done a lot to streamline that process and to get data from employers. We also have data from state all-payer claims databases, or APCDs. An advantage of working with APCDs is it's a huge chunk of data for a given state and market, and really allows us to have lots of insight into a state. For this round of the study, we now have data on 12 APCDs. I think that's the largest study of APCDs in the entire country. And then we've also been able to get some data from individual health plans. With this data, we collect it from all these different sources, standardize it, and aggregate it across all the different data contributors. And then we look at prices, particularly for hospital care, in two different ways. So the most common way that we measure prices is relative to a Medicare benchmark. And so this is the percent of Medicare pricing. And so essentially what we're doing is we're saying how much is an employer paying for hospital care or private insurer relative to what Medicare would have paid for the exact same service, the exact same provider on the exact same day. This is, I think, a pretty interpretable way to look at prices. If you see that one hospital is, say, 300% of Medicare and another hospital is 200% of Medicare, that's a pretty intuitive way to look at prices relative to a national benchmark. The other advantage of percent of Medicare is that Medicare adds in lots of additional payments, such as payments for hospitals that do lots of teaching or have lots of lower income patients or are in higher cost of living areas. And so it's probably reasonable to adjust for many of those factors. But some employers may say, look, it's great that Medicare has those additional payments. We just want to have a dollar comparison and not have those, relative to the Medicare benchmark. And so we have a secondary approach that is essentially just adjusting for differences in procedure and population differences and having a dollar price difference for prices. And so we call that the standardized prices. Once we've measured prices for hospital care, we have a public hospital report where we summarize our findings and talk a lot about the policy implications. We also have data on the RAND website that posts hospital prices for now about 4,000 hospitals and kind of slices and dices prices a bunch of different ways. And we've also worked with the Employers Forum of Indiana to host the SAGE Transparency Dashboard. So that's a tool that EFI, or the Employers Forum of Indiana, has developed that has, I think, a lot of pretty intuitive ways to search and look at prices, and also combines data from many other sources. And then some employers may say, look, it's great that we've got all this national data, but we just care about our population so we can be an effective purchaser. And so we have what's called a private report that kind of just focuses on a given employer or purchaser. And so before getting to the results, first off, why should we care about prices in healthcare? And there's been a lot of, as we doing the study discussion, that look, prices aren't actually that important, and we should care more about things like total cost of care or value of care. I think that's potentially a little bit misguided, and I think prices are really critical for thinking about healthcare markets. So in the United States and in commercial insurance, we rely on private markets to provide access to care and to finance the healthcare system. And in any economic market, it's important to have both price transparency and competition if we're going to have an efficient market allocation, which we rely on. And then the second point is that in our percent of Medicare approach, we're using Medicare as a price benchmark, not as a price endpoint. And so again, we're comparing hospitals relative to what Medicare pays. We're not saying that employers, again, to the point that we don't really know what the right price is, should be paying prices that are at Medicare rates. The advantage of using Medicare as a benchmark is that it's the largest purchaser of healthcare services in the world. The methodology for determining Medicare prices is pretty transparent, so anyone can go to the Medicare website and see the exact formulas they use and learn exactly how much they pay for a given service and provider. And there are also things that have been developed with lots of stakeholder input from providers. And I think another point is that Medicare rates, while not perfect, are roughly designed to be the break-even rate for efficient hospitals. And so when you compare relative to Medicare, you're essentially comparing relative to what should be a pretty standard break-even point. And so as we've done the study, for this round, we've collected what's probably the largest database that actually allows for identification of individual hospitals. We have over 4,000 hospitals and 4,000 ambulatory surgical centers, which are provider organizations that provide mainly outpatient services. We have about $100 billion in healthcare spending and about 5 or 6% of total commercial hospital spending in the United States. And we actually have 17 states where we have more than 5% of commercial spending. And so that's a pretty robust sample, especially in those states. So what do we find? So there are really kind of three main points that we'll go into much more detail on. The first is that employers pay prices that are 2.5 times, so exactly 254% on average, what Medicare pays. There is a tremendous amount of variation in prices that is not explained by quality or cost shifting, and instead is explained by market concentration and provider dominance in certain markets. And just one final point too. So I mentioned earlier, Medicare rates are nationally close to break even, and we see that here where the national break even rate, if we use the cost report data that hospitals report to Medicare, is negative 3.5% or 3.7%, but there's lots of variation with many hospitals being quite profitable under Medicare payments. So into our main findings, so on average, hospital prices are high and quite variable. On average, employers pay hospital prices that across the country are 254% of what Medicare pays, but we see a tremendous amount of variation. So for example, in some states like Arkansas, Iowa, and Michigan, hospital prices are less than 200% of Medicare. On the other side of the chart, we have some states like West Virginia, Florida, and Georgia, where prices are well above 300% of Medicare. So again, keep in mind that this is a $500 billion market, and we see almost a 2x range in prices across the country for hospital care. Just focusing on the particular alliance states, Illinois and Wisconsin, we see, again, the same two extremes, where Illinois prices are actually just below Medicare rates at about the national average rate, rather, at about 245% Medicare. And Wisconsin, as has been the story in past rounds, is towards the top at over 300% of what Medicare pays. When we looked at prices, we looked at both facility fees, and so this is the amount that goes to the hospital organization, as well as professional fees, and so this is the amount that goes to physicians mainly, or those who provide your care. And what we found is that if we just look at the professional fee component, there's overall lower prices nationally. So the national professional fee price is around 160% of what Medicare pays. And on average, there's just not nearly as much variation, but we do see some strong outliers. And so I think most notable thing is that in our study, Wisconsin has the highest professional fees in the country of just under 350% of what Medicare pays. Illinois is, again, towards the bottom at about 160% of what Medicare pays. And so, this could mean that in Wisconsin, at least the provider groups tend to get paid more than in other markets, and we certainly see that relative to other states. Professional fees are much higher than facility fees in Wisconsin, which is a unique story for Wisconsin. And so I mentioned earlier the other component of facility fees. And here, as I mentioned earlier, we just see that Wisconsin has much lower facility fees than they have professional fees, at least we rank them. And so they go from the highest in the country to just above the national average price for facility fees. And so at least in Wisconsin, the story is that the hospital organizations themselves are a little bit higher than the national average, but in line with the national average, but the professional fees are quite a bit higher and lead the nation. Another thing that we wanted to look at was differences in site of care payment differentials. And so I mentioned earlier ambulatory surgical centers, and what we wanted to look at is how prices for services done in an ASC compared to prices done in a hospital outpatient department or HOPD. And this has been something that has attracted lots of policy attention, particularly in the Medicare side, where there are calls to equalize and essentially have for many of these type of services a single Medicare payment. And if you look at Medicare data, what you actually find is that there are large site of care differentials where a ASC gets paid about half the price as what a HOPD gets paid under Medicare. And so we wanted to look at that in commercial populations and look at whether or not that same story is true. And so what we did here is we looked at just 5 common categories of outpatient surgeries. So musculoskeletal surgeries, gastrointestinal surgeries, laparoscopies, and intraocular or eye surgeries. And what we found is that relative to the payment differential in Medicare, which is the tan bar here, where, as I said earlier, that the Medicare payment rate for a HOPD is about twice what we see for ASCs, we actually see larger site of care differentials in commercial populations, and the blue bar here is relative to what Medicare pays. And so even though there are pretty large payment differentials in Medicare, we actually find much larger payment differentials, about twice as high in commercial populations. And so this is, I think, a pretty strong story that there's lots of price variation for healthcare. If we look at least for ambulatory surgical centers and hospital outpatient departments, we find actually no difference in quality. If anything, ASCs tend to have higher quality. And so while maybe it's a little bit distressing to see this level of price variation across different sites of care, at least one potential kind of glass half full of this, if you will, is that this is a potential savings opportunity. And so if employers can develop programs to steer patients to ASCs instead of HOPDs, then that's an area to save quite substantially. And so I wanted to just dive into what we found for a lot of the variation within state prices. And so I mentioned earlier, we see lots of variation across different states, and we went over that earlier. But we also see within the same market a tremendous amount of variation. And so if we just look at prices for the state of Illinois, we see almost the exact same story that we see across states nationally, where on the lower end, prices are about 150% or 200% of Medicare on the lower end, all the way up to over 350% of Medicare at the higher end. We see the same story in Wisconsin, except for, as maybe you'd expect, everything is shifted up a little bit. In Wisconsin, the lower end of prices are around the national average of 250% of Medicare, but we see many hospital systems that are quite high and leading the country, such as the Mayo Clinic and Advocate Health, which has prices of over 400% of Medicare. And so you might see this and say, well, is this tied to quality? Or is this something that is if we're paying 400% of Medicare, are we actually getting better outcomes than if we're paying 200 or 250% of Medicare? We'll talk about that in a few minutes, but the short answer is not really. I mentioned earlier we have 2 different ways of looking at prices: the standardized prices or percent of Medicare. And so for both inpatient and outpatient services, these charts plot where we are in at least at the state level, in terms of percent of Medicare pricing on the left hand and standardized pricing on the bottom axis. And the main takeaway is that there's really not much of a difference, at least in terms of how we rank states, whether we use or if we use standardized prices or percent Medicare prices. And so I think the takeaway from this is that no matter how you slice and dice prices, you tend to get roughly the same result or the same comparison. So we know there's a lot of variation in hospital prices, and it's important to think about what actually drives those prices. So again, if we're paying more but getting better quality or outcomes, then actually maybe we, it's a good thing there's lots of variation. Maybe we actually want to pay even higher prices. And so we actually took those questions to the data, and we'll go into these in more detail. But briefly, what we found is that there's no real correlation with Medicare, Medicaid, or uncompensated care patients, the standard cost shifting story. We found a pretty small but insignificant correlation with quality or outcomes, but we did find a strong relationship between market power and concentration. And so just to go into these in a little bit more detail, when we've done these studies, one of the things we commonly hear is that hospitals have to charge high prices to employers to offset losses on the Medicare or Medicaid side. And so we wanted to test if that's actually true. And so if that's the story, then what we should see is that hospitals that have lots of patients who come from non-private insurers, so whether this is Medicare, Medicaid, or uncompensated care, should be the ones with the highest prices. On the other hand, the hospitals that have relatively few non-private patients should be able to get by with lower commercial prices. But across these different buckets of how many non-private insurance patients you have, we find the exact same relationship between hospital price. And so there's really no explanation or support for the cost shifting hypothesis driving commercial prices. And essentially, commercial insurers, or hospitals rather, charge commercial insurers the price that they will pay and the market decides. I also wanted to touch on quality. So to look at quality, use data from the Medicare STAR system. And so this is exactly like Yelp reviews, where a one-star hospital is the lowest quality, a five-star hospital is the highest quality. And so across hospitals from both Illinois and Wisconsin, we wanted to look at, for each level of STAR, what's the range in prices and if there's a relationship. And so if it's the case that the highest price hospitals are the best, then we should see substantially more higher price hospitals with 5 stars than we see at the lower end. And so across the combined Illinois and Wisconsin hospitals, we see roughly the same stories we see nationally, where there are many hospitals that have 1 star and have high prices, so above 300 or 400%, or 2 stars above 300 or 400%, as well as many 5-star hospitals that are closer to 200%. And so I think the main takeaway from this finding is that it's really important to not have just data on price. You actually have to pair that with quality. And there are many lower price hospitals that have high quality, and many higher price hospitals that are low quality. And so it's really important when you're thinking about designing a network to have both types of information. And then nationally, in another study, we looked at what happens when hospitals increase their prices and whether or not their quality improves for pretty clinically important things like AMI mortality, heart failure, stroke, readmissions, and things that we should probably be quite concerned about. And what we found in this study is that when hospitals increase their prices, none of these quality metrics change. And so there's really no link between hospital price and quality. And so what does drive prices? And so we conducted the same exercises I talked about earlier, but instead of looking at cost shifting, looked at the link between hospital prices on the left-hand side and the market share that they have in their market. And what we find is that when we do the relationship or the correlation between hospital market share and the price, there's a pretty strong relationship. And so market share actually explains about 20 to 30% of hospital prices. I'll skip to these. And where I think this is notable is that there have been over 2,000 hospital mergers since 2001. And the way that hospitals gain market share is they purchase other hospitals or acquire and form large systems. This has been, especially in the last year or 2 years, quite prevalent in Wisconsin, and there have been some pretty notable hospital consolidation events in Wisconsin. And so we've seen over the last 2 decades over 2,000 hospital mergers, and we know that these mergers lead to higher prices. And as a result of these 2 decades of hospital mergers, essentially all hospital markets, if we're to look at the same measures of concentration that apply to either the Federal Trade Commission or Department of Justice, would use to look at any other market, what we see is that hospital markets are uniquely anti-competitive and very concentrated. And so particularly focusing on Wisconsin here, we see that the entire state is either highly concentrated or concentrated. And so in Wisconsin, we actually don't have really any competitive hospital markets. And likewise with Illinois, it's also a very concentrated market, if we're to use the exact same definitions that we'd apply to any other industry. And as a result of hospital concentration and mergers leading to increased concentration, every single study that has looked at these has shown that they lead to price increases ranging from about 5 or 6% all the way up to 60 or 70%. And so the academic literature here is pretty clear that hospital consolidation leads to higher prices. In other work, we've estimated that over the last decade, hospital mergers have led to about $4 trillion increase in employer spending on healthcare and have reduced wages by about $1 trillion collectively across the country. And finally, we also know that hospital mergers don't actually lead to improvements in quality, and if anything, lead to reductions in quality. So we're paying more and certainly not getting any better care. And if that wasn't concerning enough, there's a new and growing form of consolidation called private equity, which has really skyrocketed over the last several years and now accounts for over 1,000 transactions in healthcare per year, with about $1 trillion collectively invested in private equity transactions. And so I think it's important for policymakers and regulators, and I think employers can do a lot to be cognizant and to call alarm to this issue, to make sure that we don't end up at 20 years as we have with hospitals with the exact same lack of competition among markets due to PE. And so that's a lot on price variation and what drives price variation. But I think it'd be really helpful to just take a step back and to think about why we end up here and what are some of the paths going forward. And so as we've been doing the study over the last now 5 rounds, it's been really interesting to just kind of get out there and talk to purchasers, policymakers, providers, and insurers, and people really kind of involved on the ground. And as we've been doing this, there are really, I think, 4 quotes that really stand out in terms of being emblematic of potentially the issue around hospital prices and a lack of competition or transparency. So the first comes from a executive at a large nonprofit hospital system in the state of Colorado, when asked by a local school district or a collection of school districts to do something around prices and try to kind of think about innovative models, just simply said, tough luck, we're going to charge whatever the market will bear. And so again, this is a nonprofit hospital system that presumably has some social responsibility to be a valued community member. The second quote rather comes from a executive of a large TPA, and to be clear, we've had tons of great work with many TPAs from across the country, but this individual TPA didn't believe that information on prices was valuable to employers, and instead didn't want to bring confusion to them, or wanted to make sure that they controlled the information to employers. So again, employers have a fiduciary obligation, not their brokers, their TPAs, et cetera. And so it's really important for employers to actually be the backstop and actually know information on prices negotiated on their behalf. And maybe some of that, insight from the TPA actually might be true from the next quote from a health benefits director at an employer that had a premium of not $24,000, the national average, but actually about $35,000. That we don't know why our spending is so high, but our consultants and our brokers tell us we're doing everything right, and so we don't need to worry. So again, employers themselves have a fiduciary obligation, and so they need to monitor their own data. And then finally, the final quote comes from a legislator at a state that actually was doing a lot right and has lots of, I think, pretty innovative payment models, which was, we don't want to put our hospitals at a competitive disadvantage and not recognizing that lower prices are a benefit to workers in the state, and increasing prices are essentially a tax on workers. So what's the road ahead? So I think it's important to keep in mind that whether or not they like it, employers in the United States are in the healthcare business, and they've got to make lots of business decisions around healthcare that are becoming much more real given fiduciary obligations. And a lot of what we see both through the Consolidation Appropriations Act, as well as some of these emerging lawsuits around fiduciary obligations. Policymakers have largely been slow to act, but I think there's a lot happening that is encouraging. Just one example would be Oregon now has a policy that requires ownership disclosure. I think this is particularly important for private equity acquisitions. The state of Texas has implemented anti-competitive contract provision ban. So two very politically different states, but are tackling the issue around consolidated healthcare markets and healthcare prices head on. And then at the federal level, there have been Federal Trade Commission actions on non-competes, consolidation, and also private equity. And then finally, the Medicare system is, I think, slowly but potentially moving towards site-neutral payment policies. So just to wrap up, what can you do as a employer or purchaser? So one, I think it's really critical that employers have access to their own data and actually use it to inform decisions. And I think there's some examples of employers that have actually used this type of data to really innovate and be examples of how you can be a responsible purchaser. So on the one hand, CalPERS, or the California Public Employees Retirement System, noticed this exact same ambulatory surgical center versus hospital outpatient department price differential many years ago, and actually developed policies to steer patients towards ASCs and recognize that they would save money and actually improve quality by increasing the use of ASCs. And so CalPERS saved about 20% on shoppable services and about $100 billion nationally. Or if this were to be expanded, rather, it'd be about $100 billion nationally. Another example comes from the 32BJ Health Fund. This is essentially the union or the purchaser on the behalf of the union for New York City, essentially service workers, so doormen, a lot of trades individuals. And what they realized when they were looking at their data is that they were paying a particular hospital, the New York Presbyterian System, over 300% of what Medicare pays. And so they used their own data and actually noticed this and said, look, this hospital is, which I have a picture of one of their outpatient wings here, is really great, but we're going to make a economic trade-off where we're going to decide not to have this hospital in our network, and instead we're going to pay our workers more in take-home dollars instead of healthcare dollars. And so as a result of this program, the union saved about $100 million, and were able to actually both give all their members a $3,000 bonus, as well as the largest pay increase in the union's history. And so this is, I think really highlights how real many of these decisions are. And then finally, reference-based pricing is something that can save money. So one example comes from the state of Oregon, where they actually recognize the same level of price variation that exists in every state and cap prices at 200% of Medicare for the state employee plan, as well as teachers. And this led to savings about $50 million per year, which is something that can be certainly achieved in other states as well. So just to wrap up, and then I think we have some time for questions. Healthcare costs, which have really taken off and grown exponentially over the last 2 decades, place a tremendous amount of pressure on employers and come directly out of worker wages. The potential opportunity here is that this large variation in healthcare prices and spending, which is not, again, correlated with quality or access differences, presents a potential savings opportunity if you can design programs to steer patients to lower price providers. Employers and purchasers need to demand and use information on prices that they're paying and are being negotiated on their behalf, and employers in particular have a fiduciary obligation to make sure that those purchasing decisions are being done efficiently. And then finally, I think it's also really critical for policymakers to ensure that purchasers and employers are on equal playing fields and that healthcare markets are competitive. So thank you. Happy to answer questions over email, and I think we have some time for questions now.
Yes, we do. Thank you so much, Chris. We actually received a few questions in advance of today's session. So I'll start with Mike, who is wondering, how have Wisconsin prices versus Medicare changed over the past years? For example, was it 300% of Medicare in RAND 1.0? and it's 333% of Medicare and RAND 5.0?
Yeah, that's a great question. So we have seen an increase in Wisconsin prices over time, and relative to Medicare, and so now increasing up to 333% of Medicare. I think one thing to keep in mind is that when we look, Medicare prices are increasing over time, and so we're actually seeing, when we say increase in relative to Medicare, is actually an increased divergence relative to an increasing Medicare rate.
So stacking up, it's all stacking up. John is wondering, is the sample data used for the RAND study for Wisconsin representative of Wisconsin hospital prices generally?
Yeah, so actually this is, I think, one of the fun parts of the study is the first year we had Wisconsin, I think was RAND 2.0, where, frankly, we just didn't have great data from Wisconsin. And so the Alliance, as well as some other groups, was, I think, very active in reaching out to employers and highlighting the benefits of participation. And since then, we've actually had a tremendous amount of data from Wisconsin. And Wisconsin has been consistently one of the states where we actually have the most employer data.
Great. I have a question from Taylor. How do we apply this information into pragmatic solutions employers can use for their workforce? Do you want to start it off, and I'll maybe add to that?
Yeah, so I highlighted just 3 quick examples of how employers have used, 3 very different employers and purchasers have used this type of data. I think the most pragmatic thing that an employer or purchaser can realize is that there's a lot of variation in prices, both across providers and across sites of care, that isn't linked to quality. And so if you identify the lower priced, high quality providers and develop programs to encourage the use of those providers, then that's a huge savings opportunity.
And I think when it comes to the Alliance, this is where we're really trying to encourage people to use their own information for steering and tiering within their benefit plan designs. So helping employers understand that if they can find those physicians and different provider locations that are providing good care at a good price, you can incentivize your employees to go there and save not only the employer, but your employees' dollars as well. So that's kind of what we've been recommending here at the Alliance. I see we have some questions in the chat. So in the small group market segment, when claim data and plan utilization reports aren't available, how can these groups gain information on their plan group to better manage it? Do you have anything to say about that, or do you want me to chime in?
Yeah, I mean, I'd love to hear your thoughts. I mean, I do think that what we talk about when we talk about like getting access to your claims data and monitoring prices, negotiating on your behalf, I mean, that's frankly much more of a large group question, but I still think that a lot of these steerage and other types of benefit designs still apply to small groups.
And that's exactly what I was going to chime in with. We still have the ability to look at the data within this area and say where we think you can provide better care at better prices. And so even if we can't say you have had 3 MRIs that if they had gone here would save X amount of money, you could still implement plan design that would encourage people to go to that office visit instead of the ER, to go to lower cost options. So I think there's ways you can do it even if you don't have your exact data. I'm gonna see if there's any other questions. There's one thing that I did want to touch on. I think you talked about reference-based pricing. So what the Alliance does is actually reference-based contracting, and I just want to make that distinction for the audience, because when it comes to reference-based pricing, those providers can decide not to take that 200 or 300% that is offered, which is why we try and build it into our contracts. So, and I've got some more questions coming in. Has anyone ever done a comparison of the per capita spending on healthcare in the employer-based system in the US versus the national health system in the EU or UK? Given prices and the employer-employee contributions, is it possible there's a lower spending in national programs? I don't know that your study addressed this, but maybe you've got some other research.
Yeah, so happy to talk about that. But before doing that, I actually want to flip back to what you just talked about,
Oh,
reference
yeah.
pricing versus reference-based contracting. I think that's a really important distinction. So, I mean, I talked about two kind of broad reference pricing examples. So CalPERS is kind of reference pricing 1.0, where it's, this is how much we'll pay, and it's kind of up to you as the patient to navigate, and that saves money, but it has the downside of exposing patients to potential balance bills. And what the state of Oregon did, it's kind of, reference pricing 2.0 is actually saying we're going to negotiate the price and, not have the patient exposed to a higher price or, potential provider charges. But then, yeah, I mean, so in the United States, I mean, collectively, we probably spend about $1 trillion on healthcare, more than other countries due to high prices. And if we look at the United States, particularly the employer system, relative to other countries, prices are much, much higher. And that's really what drives, the difference in overall spending. So in the United States, we spend about 20% of GDP on healthcare. In comparison to other countries, it's about 12 or so percent. And that difference is almost entirely due to prices. I mean, we use the same amount of MRIs, hospital beds, all that type of stuff.
Great. And then can you talk about maybe the difference between Illinois and Wisconsin? They're right next to each other. Do we think that's just the market concentration? I think you talked about consolidation as part of that.
Yeah, so in Wisconsin, we know that there are several large health systems in provider groups that are, I think, uniquely important relative to other states. And that's really, responsible for driving a lot of the variation prices in Wisconsin, or the higher prices that we don't see in other markets.
In your study, what was the percentage of eligible employers in Wisconsin and Illinois that contributed?
Yeah, I don't remember that off the top of my head. We did have, again, we've consistently had over the last several rounds pretty robust participation from Wisconsin. Admittedly, a little bit less so from Illinois, but I don't remember the exact number off the top of my head.
Okay. For employers who participated in the study, RAND has been able to provide private reports to the employer. These private reports summarize the claims data specific to the employer's population at the hospitals they use. So it looks like, it says RAND also helps to negotiate the data agreements to be analyzed. That wasn't really a question. So I believe all of that is accurate.
Yeah, that's something that Brian Briscombe, RAND, I think was on the call today, has really been leading. And I mentioned that this is kind of the final piece of getting data out, is that we actually have this option to, not say to an employer, this is kind of what prices look like nationally, but this is what prices look like in your plan. And then that allows the employer, the purchaser, to actually inform whether it's their benefit design strategy or their negotiations.
Thinking about Wisconsin, if as a percentage of Medicare costs were high, is there a reason to suggest Medicare reimbursements in the state are too low so that our shift to private pay? I think you kind of talked about the fact that there maybe isn't that, but if you want to elaborate.
Yeah, so yeah, that's something I think is worth spending some time on, is that, a common argument is, healthcare markets are almost like reverse Lake Wobegon, where everyone's patients are sicker and everyone's underpaid. But if we look at the actual data and try to do the correlation between how much are you paid under Medicare and potentially, not making your costs in Medicare versus what are you charging in the private market, we don't find any correlation that type of cost shift is happening. And I think what's really going on is that providers are charging what their market will bear. And in some sense, the way you get high commercial prices is you be an attractive hospital to rich people, and that really doesn't have anything to do with how much you get paid under Medicare. And then Medicare, another advantage is that if you are in a, say, high cost of living area, there are those types of adjustments. But again, we don't find that really explains what happens on the commercial side.
And just confirming you're not including Medicaid into any of your benchmarks, correct?
That's right. So this is just the Medicare fee-for-service price as the benchmark. We don't include Medicare Advantage or Medicaid, either Medicaid fee-for-service or Medicaid managed care, just because it's not clear that those are the right benchmarks we want to use, and there's just not really much transparency into those prices.
And I'm going to take one more question before I wrap up. How much negotiating power do employers normally have to drive down hospital prices? Does this depend on market forces? So I have thoughts, but I'll let you chime in.
No, that's a really great question. I mean, if you look at how employers purchase any other service in the organization, they negotiate prices and they monitor prices. But for healthcare, a lot of that kind of business sense just doesn't get applied, and so I think employers are sitting on negotiation leverage, and the first step to actually understanding that is to look at your own data and understand where you are relative to the benchmark. I mean, if you look at for example, the 32 BJ union in New York City. I mean, they're given the size of New York, not that big, but they looked at their data and made economic decisions that led to pretty substantial savings.
And I think the other thing you can do is negotiate with your utilization, right? If you can try and drive patients to different cost centers, ideally, that's where the Alliance comes in, and we're trying to pool employers together to try and help with that negotiating power. But I think that's what we're encouraging people to do right now. If we can get good care at a good price, let's go to those centers rather than, the example you gave of 32 BJ. They said, okay, if they're not going to negotiate, then guess what? I'm going to remove them from the plan. Even if you don't remove them, maybe you could tier them differently or incentivize your employees to go to them differently. And I think, we're hoping those market shifts will help our provider partners maybe negotiate with us in a different way for different care. So,
yeah, and I guess, especially on the outpatient side, I think there are, even though there's maybe not a lot of competition on the hospital side, there is quite a bit of competition. Just if you look at all the independent ASCs or other types of groups that do lots of outpatient care, and those providers I think are much more willing to negotiate and be effective partners.
Great. Well, thank you so much for being here today, Chris. And I'm going to do just a couple of wrap-up slides before I let you all go. So just a reminder, if you're an employer member of the Alliance and you need access to resources, or if you're interested in learning about self-funding, please feel free to reach out to me. There's a QR code on your screen, but just want you to know we're here to help. We're going to try and continue to change healthcare. And if you want to meet with us in person, please know that we've got some upcoming trade shows we'll be attending, but also we have some data workshops to kind of delve into your data. These are going to be taking place in person in Wausau, Eau Claire, and La Crosse. All three of these workshops are the same, so pick the location that works best for you. At this time, we aren't recording those because they are meant to be sessions where we're helping people go through data and understand how that data would change their benefit plan design. If you would like resources from today, you can access them again through that resources button, or feel free to email events@the-alliance.org. For CE credits, Wisconsin brokers and consultants, please download the attendance form. You have to have attended the entire session for today. And please provide feedback. We hope these sessions are valuable to you all, and we hope that you let us know what else you might want to hear about or if there are things we can do better. The slides, handouts, and a recording will be made available on our events page. And thank you for joining us today. And remember, when you think of the Alliance, think self-funding smart. Have a great day.